Good evening, family and friends, and welcome to our workshop on opioid use disorder. As you know, there's a major drug opioid overdose problem in the District of Columbia, indeed across this country. And we are just grateful and thankful that our mayor and our government has thought enough to have a campaign to stem this epidemic. We are pleased that Rising Sun, among other sister churches, have been able to partner with the Department of Behavioral Health to sponsor a series of workshops and events to help educate our community about this crisis. We want to talk about what opioids are, legal and illegal. What is opioid use disorder? And what we can do. What prevention strategies can we employ? What treatment strategies are there? We hope to educate you in such a way that you will be able to identify sisters and brothers and cousins who are suffering in this area and how you can help them get some help. Our workshop tonight will be conducted by a great friend of mine. He's also most qualified to do such a workshop. He has over 30 years experience in this area. He's been a licensed clinical alcohol and drug counselor for over 30 years, working and designing programs for adults, for adolescents, and for families. He's had extensive experience utilizing a variety of treatment modalities. He has worked for the Department of Health in Prince George's County. He's doing a great work to educate and help folk in Reston, Virginia. I could go on and on about his credentials, but he will introduce himself to you when he comes. I do want you to know he is a great friend of mine. Amen. Married to a great friend of mine. Amen. He is the first man to Reverend Dr. Gene Casey, the pastor of Martin Luther King Church. There he serves as the associate pastor and works in the area of counseling and healing. He's a major help to her in that ministry over there in Reston, Virginia. I met this brother down in seminary, amen. He is a fellow seminarian down there at Virginia Union University. We graduated together in 2010. We worked together. We fellowshiped together. We learned together. And the relationship has continued down through the years. And so I'm just so grateful that when we made the call, he answered the call and came to Macedonia to help us. Amen. So the next voice you hear will be that of our presenter, God's man, the associate pastor at Martin Luther King Church in Reston, Virginia, Reverend Clyde R. Casey. Hear ye him.
Good evening. First of all, I want to thank Pastor Marlo Mitchell and Trustee Pamela Mitchell for the opportunity to be at Rising Sun Baptist Church one more time. It's something about this opiate workshop. It just clings to me because Pastor Mitchell told you about the educational part. But I'm going to tell you where I got my doctorate in drug addiction from a practical application. Matter of fact, in June of this year would be 40 years on the other side of using. So I'm here to let you know that you can, that the ones you're looking at that are having problems, they can recover. This opiate epidemic was on before the COVID pandemic. However, once the COVID came in, I think people thought that the other one went away. It didn't. The current opioid epidemic is one of the largest drug epidemics recorded in U.S. history for all racial and ethnic groups. From 1999 to 2017, there were nearly 400,000 overdose deaths involving opiates in the United States of America. In 2017, the opioid epidemic in the U.S. was declared a national public health emergency with 47,600 reported deaths from opioid-related overdose, which accounted for the majority of overdose deaths. Over 81,000 drug overdose deaths occurred in the U.S. in the 12 months ending in May 2020, the highest number of overdose deaths ever recorded in the 12-month period, according to the recent provisional data from the Centers for Disease Control and Prevention. While overdose deaths were already high in the months preceding the 2019 pandemic, the largest number suggested an acceleration of overdose deaths during the pandemic. You see, the disruption to daily life due to the COVID-19 pandemic has hit those with substance use disorders hard. 3 decades ago, when opiates and crack cocaine was devastating African American communities, the national response was the war on drugs. This resulted in widespread incarceration of drug users and disruptions of primarily African American families and communities. This population was criminalized for drug-related offenses at much higher rates than white Americans, and this has had lasting effects through the present day. However, today's epidemic has no boundaries. It has made its way from city centers into the neighborhoods of suburbia and down the back roads of rural America. Opiate addiction has wreaked havoc on nearly every demographic, but it's particularly hard on those without a 4-year college education, and specifically the Caucasian population. With Caucasian men reporting high rates of addiction and Caucasian women experiencing high rates of overdose. And since it has hit this community, today the response to the drug epidemic is framed as an urgent public health issue. Substance use disorders and addiction are now viewed as a health condition, a disease that needs to be prevented and treated, and where recovery is possible with appropriate services and support. Well, today we're going to discuss some of these principles, some of these opportunities, some of these ways we can help get our family and friends some help. And we're going to start this conversation with the first slide. These are the learning objectives. At the end of the session, we hopefully that the participant will be able to describe the opioid crisis in the District of Columbia, combat the myth about substance use disorders, describe what the District of Columbia is doing to combat the crisis, list different types of opiates including fentanyl and their effects, discuss signs of addiction, describe the 3 Food and Drug Administration approved medication-assisted treatment, know where to go for treatment and recovery support services, give examples of harm reduction, identify signs of opioid overdose, and discuss the benefits of the Good Samaritan law. You know, from working in the field of addiction, we all those many years, I found it was so difficult to get services because it's always with some red tape and all those type things. However, this addiction, this process became so difficult to handle that the Donald Trump and 25th declared a state of emergency back in October 2018. This allowed the Department of Health and Human Services to cut red tape on federal funding to allow the development of programs to help combat this disease that's taken over the nation. And that's what we're doing now. It gave us an opportunity to faith-based and anything, whoever was trying to help to get the word out. Second. September is Recovery Month. That's like saying February is African American History Month. For me, every month is African American History Month, and every month is Recovery Month.
All right.
Next slide, please. Strong communities make for strong recovery. See, recovery it's like a rope. You have to have a good foundation, and everyone is a part of it. And the players in this is the families and friends, consumers and clients, neighbors, community-based organizations, faith-based organizations like this, employers, service providers, policymakers, and elected officials, peer specialists, and recovery coaches. See, like when I was working with things happen, there's I'm gonna say about the peer recovery ones. They're the ones that's been through it. It might not be had the degrees to go in, but however they have the experience that we could put into place to bring it around to make it real for them. Next slide, please. Truth about substance use. That's the substance use disorder. This is the data from 2018, and 20.3 million people aged 12 or older in the U.S. experience a substance use disorder. 10.3 million people aged 12 or over misuse opiates. Adults had a co-occurring, 9.2 million adults had a co-occurring mental illness. It's so difficult with that co-occurring mental illness, especially on the treatment side of it, because you have to deal with two tracks. You have to deal with the mental health track, like maybe depression or bipolar, and then you have to deal with the substance. And you have to see what came first, the chicken or the egg, and how, so you have to treat both of them. So it's all of this contributes to recovery. Next. This gentleman here is the face of DC opiate crisis. You would see heroin is the most commonly used opiate in Washington, D.C. However, this is a great picture of it, because this is what you see. You don't see the pictures, the majority of users, not the millennials. It's the ones like this, 40s, 50s, 60s. This is the picture of it. Next. And as I say, the profile of DC heroin users, as I say, this gentleman here, 88% using more than 10 years, 59% using more than 25 years, and 22% using more than 40 years. And of them, 73% of them are over 40 years old. And 59% over 50 years old. I don't see how they stayed that long. I mean, it whipped me so bad, though. When I was 30, I was ready to get some help. Next. And this is the DC overdose deaths increase. You can see the increase. And as I said, in 2017, that's when it really peaked. And that's when the Trump declared, someone brought it to him, and then in 2018 they declared a national emergency. Because what's happening, I was at Chautauqua, and we were talking with other pastors and everything, and this was pastors was pastoring in West Virginia, right on the line of Ohio. And they were saying how it really wreaked havoc there, and the pharmacists And the pharmacists took advantage of it. They said that along the line, the main line between West Virginia and Ohio, there was about maybe 20 pharmacies there. And you know nobody, and they was prescribing these opiates because the pharmaceutical companies would keep it out there because they had great lobbyists up on the hill. Next. And you see the peak. You see the highest the depth. However, that blue line is the peak, how it is 2020. And that's right after that pandemic hit, and they couldn't get out and stuff. And it peaked up like that because it just upset the whole family, the whole lifestyle. And that's the only way they had to cope. Next. This is the DC opioid-related deaths snapshot. 1,148 opioid-related deaths to January 21st, January 1st, 2014 to April 30th, 2020. And 84% were African American, and 76% were ages 40 to 69. The most prevalent age among age was 50 to 59, and this is letting you know. And the different wards that the African Americans are presiding in, those wards, that's the numbers were up. And it's almost like Travis Smiley said, when white America has a cold, African Americans have pneumonia. So we get the blunt of it. Next. And this is to say the deaths by ward. Affects 8 wards, but the most prevalent are Ward 5, which we're in right now, Ward 7, which is over in Benning Heights and Benning Road area, and Ward 8, Anacostia, and Congress Heights. I used to call that on the island because the people living on the island, because they got this bridge to cut it off. When you cross the bridge, and that's where most of us was placed, on the other side of that bridge. Until now, they're doing a little changing now. The complexion is changing a little, however, not the rate of overdose. Next. Live long. Live long DC goals. Reduce legislative and regulatory barriers to create a comprehensive surveillance and response that supports substantial solutions to emerging trends in SUD and opioid-related overdoses and opioid-related fatalities. What happens, this is different from war on drugs. However, somebody listened, because they did it that way, and we learned from that way, we know we can do it a different way in a different way, so we go benefit from it. And the other one is the goal to educate DC residents and key stakeholders on the risks of opioid use and effective prevention and treatment. It's not only it costs the family, it costs the whole community when addiction is not treated, because they're the ones who get all the blunt of the addiction. Because the people who are mostly addicted, they don't have no transportation to get out the neighborhood, because the crime and stuff is done in the neighborhood. So it's to our benefit to help. Engage health professionals and organizations in prevention and early intervention of substance use disorder among DC residents. Support the awareness and availability of and access to harm reduction services in DC. Harm reduction services, needle exchange, HIV testing, condoms distribution. All those things are harm reduction. Ensure equitable and timely access to high quality SUD, substance use disorder treatment and recovery support services. because, and develop and implement a shared vision between Washington, D.C.'s justice and public health agencies to address the needs of individuals who come in contact with the criminal justice system to promote a culture of empathy for their families and residents, and develop effective law enforcement strategies that reduce the supply of illegal opiates in Washington, D.C.
Brother Clyde, we do have a question
Okay.
about something you stated, and indeed, we encourage those that are listening in to send your questions in if you have them. Did people using heroin start out using some other drug?
The majority of them do. As you would notice, they used to say that marijuana was a gateway drug. However, as we go along further down here, you'll find out that opiate, like Oxycontin and the pharmaceutical drugs, were the first, is the gateway drug to get them into heroin. Next, please. I hope I answered the question. Evidence-based and proven strategies that work. Emergency department treatment for overdose survivors. Widespread, because when we come there, we want to get help. But one time they throw them to the side and say, wait, like they cause their own problems so they can wait for someone else. However, now they're aware that addiction is a disease and not a social problem. It's a disease. And widespread distribution of free life-saving naloxone. And we will talk. Naloxone is kits like this, we'll talk about places where you can get distribution from it. And they're going to have we'll have another workshop here in a few months, and they'll be able to tell you also and distribute some of the naloxone. So that's in the making. And the other one is continued treatment in jail. Just because we want to get some treatment in jail so they don't come back. Because most of the ones who are in jail are African Americans just because of drug-related. And persistent street engagement of heroin use to encourage treatment. To let them know there's another way. And to meet them where they are. Workforce development. We have to get some type of value. What happens after you get clean? What do we do now? We provide a way for some workforce development. Expanded medication-assisted treatment. Easy enrollment in treatment at community enrollment sites. Peer recovery coaches and peer-led community centers. Housing, job support for sustained recovery. Prevention activities in public and public charter schools. It's almost like when we come out of it, out of addiction, and work on a recovery program, getting in recovery, we need these things. It's almost like slavery. When the emancipation came over and said, "You free." Well, what we do now? We ain't old enough, never worked. No, what we do now? We have to have someone to guide us through that, and that's what these other parts do: the peer recovery, sports, housing, recovery coaches, and all those things. That's what we do to set in place. As I said, that when we told about how it built a strong community, these are some of the people who do that, who is in charge of doing that. Next. Goal 2. Educate. 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 DC residents and key stakeholders on the risks of opiate use and effective prevention and treatment options. Holding community conversation in all 8 wards. We're doing that now. Partnering with community and faith leaders to raise awareness. Doing that now. Training family users and communities on the saving naloxone. We're doing it now, and we'll further do it in the next opportunity to present this. Conducting social public awareness campaigns to prevent opiate use and prescription drug misuse. A lot of that has to do with seeing what people you're putting into office. and see what's on their agenda. Say, okay, is this part of your agenda of stopping the drug use and stopping these pharmaceutical companies from flooding our neighborhoods with all this stuff? Creating a welcoming environment to sustain individual recovery and promote community relevancy. What happens with this community, when we come back to the community, we can't treat them like they was when they left the community. We have to understand that they're recovering and change. A lot of times we don't want them to be changed, because that means we have to change. We have to do something different. We have to open up and understand that this is a disease, and we have to help them to get on their feet, because it's, as I said, it's not just good for him, it's good for the whole community. And engage in heroin use to encourage treatment and save lives. As I said, the needle exchange, testing for hepatitis C. Now, what are opiates? They naturally originate from the opium poppy plant. Opiates are a class of drugs that include the illegal drug heroin and synthetic opiates such as fentanyl and pain relievers available legally by prescription such as Oxycontin, hydrocodone, which is Vicodin, codeine, and morphine. What happens with this, especially when I go to the doctor and they ask me, oh, we have to give you some Oxycontin or something like that, I tell them, I say, no. Is there anything else you can give me? However, if that's what I have to take to heal, if that's what I have to take, what I do, I give them to my wife. Because see, I'm an addict. I'm just on the recovering side. And once I take this Oxycontin, I don't know if I'm taking it after it gets in me. I don't know if it's for pain or to get high. So I don't want to put myself in that position. And the second thing is, if it's true and they do give it to me, once I take it and don't need it anymore, I destroy it, dispose of it properly. I don't keep it around. You have another question?
Another question.
You mentioned that we have folk in prisons that have this problem. What type of drug abuse treatment is available to prisoners?
You know, there are quite a bit. They have support like Alcoholics Anonymous and Narcotics Anonymous. They come into the prison and they give meetings. They have counselors from the state work in the jail. They have different sections, like they have jail-based recovery programs. They have like up in one of my friends. He was a director. He was in charge of the jail-based recovery program. They separate them from the other ones who the other population. They say they have counselors, and so it is available in treatment.
Including the medically based treatments?
What's that?
Including the medically based treatments?
I don't know about the now, because I don't think the medical assisted treatment is not in there, because they already are separated from heroin and all that, okay, supposedly. So that's not available. However, absence and recovery support programs are available there. Effects of opiates. It's commonly used to block pain signals between the brain and the body. Can make individuals feel relaxed, happy, or high, and can be addictive. Can result in slow breathing, constipation, nausea, confusion, and drowsiness. Those are some of the things. And as I said, when you once, and this is the other thing, once you cross the line of addiction, I know. That's what keeps me clean. Once you cross the line of addiction, there's no way you can go back over and do something safely. That's from my experience. So so those are some of the things, and what is fentanyl? I'm gonna tell you about this fentanyl. When you're on the streets using drugs, you know what the advertisement for good drugs? The advertisement for good drugs is say, "Whoa, Pastor Marlowe just overdosed." We running over there because they know that's good drugs. And then we're going to lie to ourselves and say, what I'm going to do, I'm not going to put as much in there. And what happens with this, to make a good drug, this fentanyl is put a cut heroin with that. And that's when the overdoses this flew up. Because as they say, it's a synthetic opioid that is 25, 50 times more potent than heroin. And it's the leading cause of opioid overdose. It's more so on the East Coast than on the West Coast. Because on the East Coast, the drugs are lighter. And on the West Coast, they have the opioid heroin is, they call it mud, or dye. And so you can see this, you can see the mix of that. Yeah, you can mix it here, you can't even tell it. And the fentanyl is 100 times more potent than fentanyl. And it's all about economics. They don't care about lives, they're about economics. So it's a terrible thing. It's a terrible thing. And mixed drug use can be there. Before the fentanyl, really one of the main reasons for overdosing was mixing with other drugs. And what was the main one with heroin overdoses was alcohol. Because you would get drunk and didn't know how much you did and all that, and so you mix it and it to increase the effect, and you don't know what you did, you don't know what was last, and that's what the overdoses was a major reason for overdoses then. Now is because of all the different mixes and stuff. And the main thing I want to let you know, the ones who are out there using, they don't know what they're getting. They're not chemists. You know, they don't know the makeup of anything they're getting, so it's just a dangerous situation. And as I say, they mix heroin with other prescription drugs and alcohol with clonopine, Valium, and Axine. Most fatal overdoses are a result of polydrug use. Next. What does opiate addiction look like? It's the inability to consistently abstain. It's impairment in behavior control and cravings. It's diminished recognition of significant problems with one's behavior and interpersonal relationships. It's a dysfunctional emotional response. And without treatment, our engagement in recovery activities, addiction is progressive, can result in disability, and most of all, premature death. That's what it does. And that's what addiction does. Addiction wants your life. And it was, before I got recovery, I mean, it whipped me so far down that my ability to dream had died. So I know what it does to you. However, I know what's happening on the other side too. What is opiate use disorder? Opiate use disorder is a chronic disease that requires appropriate treatment and recovery support. You know, you just come up and tell them, why don't you just stop? You know. 2 million or 7% of the population aged 12, see, 12 or older in the United States misused opiates in 2017. 20% of individuals with opiate use disorder receive treatment. and effective OUD treatment is available. It's available because of the law that came out, the 2018 that Trump signed. So it is available, you know, and it's available through, in the same month that Trump signed that in 2018, the same month, Congress passed the Support for Patients and Communities Act. This legislation changed Medicare reimbursement, treatment, bed allocation, and prescription restrictions for medication-assisted therapy. It also expanded the availability of naloxone to the first responders and pharmaceuticals nationwide. So things have been put in place. It's not that we don't have them in place. Things are in place. Sometimes, most of the time, it's because we don't have information about it. And hopefully, the information you get tonight, you'll pass on to someone else. So, because information saves lives. And with these different medication-assisted treatments approved by Food and Drug Administration, Methadone, Buprenorphine, naloxone, and counseling, recovery service and support, and peer support. See, it all's involved. We don't give someone some medication without some counseling. Counseling is a very, very big part of it. And what's happening during this pandemic, it's been a problem because so what happened, because of the COVID-19 pandemic, the Drug Enforcement Administration issued guidance that allowed practitioners to prescribe buprenorphine to new patients with opioid use disorder following a telephone evaluation. This allows patients and physicians to stay distant during the pandemic while still providing patients with a necessary tool to offset their substance use disorders. It allows patients to obtain up to 28 days of take-home medication so long as they are safe. With social distancing recommendations and inconsistent public transportation availability, the policy assists patients that may not be able to visit the opioid treatment program on a daily basis. So things are being put in place, you know, because of something happened. God works things out, you know. Next, please. Facts about medication-assisted treatment. Treatment can last a few years or a lifetime. If it lasts for 3 days, it's good. You know, 90 days is good. Because sometimes people have to get clean to want to be clean, so they have something to compare it with. So we want to get them in treatment, and so medical assisted treatment like the methadone and all those things is getting them in there to get them off and get them opportunity to get out of demographics that their environment that they're in. So to change environment, so you change some, if you change environments, you can change other things. It's hard to change in the same environment. And it's shown to be safe and effective in suppressing illicit opioid use, improving physical and mental wellness, decreasing all-cause mortality and overdose deaths. Relapses are common, especially in early in treatment. Medical-assisted treatment decreases risk even if a person continues some drug use. Combined with counseling, as I say, combined with counseling to encourage recovery. Peer support proven to increase program maintenance and dropout rates. These are the medication-assisted treatment. You got methadone. Most of the time, methadone is full opioid antagonist in treatment settings. The treatment settings are mostly health departments or other community treatment facilities, brick and mortar. Then you have buprenorphine. It's a partial opioid agonist. And this treatment setting is in pharmacies and physicians' office that can prescribe to you. And then in naloxone, opioid antagonist treatment setting is the same, pharmacy and physician's office. Methadone. Methadone has the longest success rate record for individuals with an opiate addiction, 1 year or more. You know, sometimes things happen for one cause and helps you in another cause. A lot of times, my understanding of methadone when it first came out to be used, especially out there in San Francisco, the merchants were the ones that tried to put that so keeping people from coming there stealing out their stores. So they started people on methadone, and what I think about the methadone thing, I wanted to have some type of way on the programs. When I was working at the ones over in Prince George's County, I want to have a way where you can detox off it and not maintenance for the rest of your life. It's just something that was just my feel on it. A lot of times they keep it in as long as needed, you know. And then only licensed opiate treatment programs can dispense methadone.
I'll ask you something about that methadone. I have known of folks that were on methadone, but they were nodding so hard on the methadone, you didn't know that they were in treatment. Can you explain why that would be?
Well, they overdose. They give them too much, where they could say, because I used it, 20. They say 20 milligrams. I told them, and I go in there and say, that's not good enough for me. I need you to up it. I need you to up it. Mm-hmm. An addict is an addict. Okay. You know, an addict is whatever it is. Mm-hmm. But say, what do you want? What kind of what would you like? Bourbon, marijuana, whatever you have the most of. Mm-hmm. I'll take that. Mm-hmm. Y'all, okay. You know. And the treatment leads to reduction in citation of illicit opioid use and negative consequences such as hepatitis, because when you're doing methadone, it's, most of the time hepatitis and HIV infections comes from IV drug use. You know, because sharing needles and stuff like that. And when you're doing methadone, as I said, it decreases the criminal behavior. Because most people can work and go to work, because they, you know, and it's used, however, it's used to treat addiction only, not pain. And takes place in a controlled setting with direct observation of ingestion, because sometimes, you know, if you don't watch them, they'll come in and spit it out and go out and sell it. You know, I mean, so everybody does something, you know, I mean, like that. And it demonstrated to be safe and effective when used with appropriate safeguards. When used with safeguards and counseling. And everything needs to be part of counseling involved in that. Next. Buprenorphine is a treatment of opiate dependence. It does not have to be dispensed. As I said, it doesn't have to be dispensed in treatment programs. It can be physician's office or pharmacy. Available in tablets containing either buprenorphine alone or combined with naloxone. The buprenorphine naloxone film is intended to mitigate injection abuse. A partial mu-opiate receptor. And mu-opiates receptors are like class of receptors that have different physiological functions like stress, temperature, respiration, gastrointestinal activity, memory, mood, and motivation. Because these receptors bind to opiates, they are also commonly referred to as mu-opiate receptors. Do you have a question?
It's a question going back to the use of methadone. The questioner says, I know people who have been on methadone for years. Isn't that still an addiction?
You know, it's hard because it's maintenance. I know people have been eating for years. Is that an addiction? It's not what you done, it's not what you do, it's what it does to you. I can't make that decision on whether it's an addiction. If they're becoming productive members of society, if they're doing good things, if they're a good father, good mother, good worker, I wouldn't call it an addiction.
Okay.
However, if they're just using it, not doing anything, and no, to change their mood.
Okay. So one can abuse methadone and therefore
Yeah.
be addicted to it as opposed to one that's using methadone to help him with the addiction.
Yeah. That's the same thing with food. That's another.
So like alcohol,
Alcohol, yeah.
which is also a drug.
Yeah.
But since they've legalized it, as you mentioned, the economics of the matter,
Yeah.
it's not frowned upon.
No. Like, it's not what you do, it's what it does to you. You know, and I can't let the state dictate whether it's addiction or not. Because, you know, alcohol was illegal. So the state started taxing and getting money off. They put so many of us in jail during the war on the drugs for marijuana. A lot of years. Now they're
getting paid.
Yeah, it's legal. So it's not what you do, it's how much it's what it does to you. Next. Naloxone. As I say, it displaces heroin, morphine, and methadone from the receptors, like the mood receptors. It blocks feelings of well-being that can lead to addiction. Given in pill form or as an injection. Vivitrol is 1 monthly injection, and Riva is an oral tablet. That's it's supposed to step down from the methadone and stuff. So it doesn't get you high. And one more thing, let me go back on that methadone too. It all depends on your motivation also, because I knew when I used to get the methadone, I knew what to take with it to boost the methadone. I knew what to get to do something. So it wasn't about my motivation to stop using. I call that call that welfare drug. You know, it wasn't so it's your motivation. If it slows you down long enough so you can hear a counselor because I have some friends that was using with, and they were using with me. As I say, I almost got 40 years, and they're still on methadone. So.
Is it possible to overdose on methadone?
Yes, it is. That's why you have to lock it up and keep it away from kids and stuff. Yeah. When they give you methadone to take home, they give you a lock, something to lock it up in.
Well, the person that asked that question said, okay, that makes sense.
Okay.
Explanation.
Okay. Access, treatment, and recovery service and support. There's a 24-hour helpline. Remember this, 1-888-7-WE-HELP. And there's the Department of, that's to get you involved with. And a lot of times now, you know, we have to understand too, it's COVID, and some of these things that we have up here is going to be difficult to get in touch with them. However, please give them an opportunity, give them a chance though. Give them a chance. And the Department of Behavior Health Assessment Referral Center, the ARC, for walk-ins and appointments. So as I said, because of this COVID-19, there's probably no walk-ins. However, I don't want to run you away from it, so go over and see. Or call and see someone you have. And then the community-based enrollment sets like RAP, Incorporated Family and Medical Counseling Services, and MBI Health Services. Access to medication-assisted treatment. It's available at community-based opioid treatment programs like community health centers and things like that, DC jail, community hospital emergency departments like Howard University Hospital, United Medical Center, Washington Hospital Center, and soon is to be at George Washington Hospital. And something else, there's the needle exchange program. Other access points to treatment and recovery, community health centers. You know, clinics, a lot of times, you know, doctors are starting to ask those type questions now. Back then, the doctors they weren't required to go in to take no minute. They might take a quarter of addiction courses in that. Now they have an opportunity to ask those type questions now and to say, you know, to help people to identify people who are using. And then they have other substance use disorder inpatient units, judicial system. I like when I went to treatment in 1980 up at VA Hospital at the Venada program. I might have been the only one in there who wasn't up there trying to beat a charge. The courts had referred him up there. However, it's not how you get there. Yeah. And then they got community hospital emergency departments. They have things to look at, maternal and child health providers. When they go in there, they take blood, and they can tell with the substance in the blood and stuff, and it could be a entry point into talking about the addiction. Emergency services, the Metropolitan Police Department or Fire and Emergency Service. I guess I'd say the Fire and Emergency Services. I don't know what working on that. I'm working through it too. And the community hospitals, inpatient places. And a lot of times I used to have to tell people how to get into those hospitals and stuff, because a lot of times it wasn't accessed like it, because most of the time it was people of color who didn't have insurance, who didn't have a system, someone who was looked at different. It's the strangest thing that and we get an opportunity to get help. When I was working in the health department, and I worked with juveniles, you know, the ones who were referred by the court system, and the ones who were referred by schools, safe and drug-free schools. They would send them to us, and 98% of the ones who were sent were African Americans or Latino. So it's treated different, and then when they get caught with something, they're treated different also, because they don't have money to get a lawyer, and they get caught up into the system. So it's a terrible thing. Okay, next. Recovery support services. These are the things that keep people clean. These are the things we just want to keep them clean, you know. And they have to give them some short-term housing to get up on your feet. Supported employment. You know, I call them therapeutic jobs, just to get back into the workforce. And get peer support. The peer support, like in those, send them to some of them meetings like Narcotics Anonymous and Alcoholics Anonymous, that they get them around people who are going the same way they're going, trying to stay clean one day at a time. And peer operated centers. And transgender health initiatives, because, you know, it is different. There's a difference. There's stigmas everywhere. In the Oxford houses, I went to an Oxford house. I got clean I was 36 years old when I ran away from home and went to the Oxford house. You know, and at the Oxford house, it's peer run. You know, it's no how it's peer run. You keeping yourself clean. You know, each other. If we want you being clean continues to help me stay clean. So it's like that. It's a good step in the right direction. Then they have day centers, HIPS Transgender Day Center and Downtown Day Service Center. These centers that get you, you know, sometimes you need to get out of the environment to get an opportunity to see something different. Next. What is a harm reduction approach? The harm reduction is a set of practical strategies that reduce negative consequences of drug use, includes a array of strategies from safer use to managed use to abstinence. You know, sometimes say opposite of using is abstinence. I think the opposite of using is community. Get me back in community. You know, because you know, like someone just wants you to stop using right away, and they didn't start using. You know, they've been using for what? So it didn't take them to get to that point. It didn't take them overnight. It's not going to take overnight to get clean. It's going to have to do some things. And a lot of times, you just start pointing out their consequences. They have to start, and they have to start receiving some of the consequences of their using. And that's what happens. So harm reduction strategies meet drug users right where they're at, addressing conditions of use along with the use itself. Next. What is naloxone? I showed you that earlier. Naloxone. It's a life-saving medication to rapidly reverse opioid overdose. And a lot of times with these kits we give to users, the ones who still using, because who are the best ones to help somebody with overdose if you're in there using with them? You know, you get them overdose, and a lot of times what's happening what happens with that, because of the Good Samaritan law, it takes the stimulus, it takes the pressure and stress away from trying to help somebody. Because if somebody overdosed, when I was out there, you overdose, if you try to help them, you push them on out the way. Some people throwing them in, people overdosed and woke up in Dipsy dumpsters because that's where they threw you. Because you go to jail. I mean, there's some stigmas and stuff like that. So this is life-saving right here. This naloxone is life-saving information right here. It's a life-saving tool. Next. As I said, it saves lives. 821 reported successful reversals between October 2019 and July 2020. 21,564 naloxone kits distributed from October 2019 to July 2020. And as I said, 28 plus pharmacies in all 8 wards. Text Live Long DC to 888-111 to receive a map of all locations where you can receive them. And they will have some to give away when they had the next community conversation here. Other harm reduction strategies: hepatitis C testing, HIV testing, needle exchange, and as I said earlier, condom distribution. All these things are helping people to get healthy. What does an opioid overdose look like? Opiates affect the part of the brain that regulates breathing. Therefore, an opioid overdose leads to respiratory failure. And the signs of an opioid overdose is breathing slows or stops, unconsciousness, falling out, or pinpoint pupils. If you walk into your house and you see someone sitting there and not moving, you go up there and you see if they're breathing, and you look at them, and next one please, and you try to wake them up or wake her up, and then You use naloxone only if the overdose victim is completely unresponsive. If they're responsive a little bit, then you start the breathing technique. You try to breathe it, you call 911 and then start the breathing technique. And perform rescue breathing. And then you stay with the overdose victim for at least 1 to 2 hours, an hour until help comes. You know, you stay with them, because if you leave them, they can go right back, go back out. And anyone providing aid in good faith to an overdose victim is protected by the Good Samaritan law. Next. Now, this is the benefits of the Good Samaritan law. It gets emergency help quickly because the person don't worry about going to jail themselves. Remove the fear of calling 911. It can save a victim from overdose from severe injury and death. We had some discussion questions along the way. However, after the presentation, we'll have some discussion questions to feel how you feel about the following as methods. We asked about the methadone and medical assistance treatment and harm reduction, and what are the ongoing resources, programs, strategies, or events that are needed to address the opioid use in our community. What can we do? What can we do? Engage conversation to increase the recognition of the opioid use disorder as a disease requiring treatment. Become informed about naloxone, encourage treatment, and call 911 if you witness an overdose. Some other things we can do too. What can we do to prevent opiate misuse? We can talk about it. Opiates can be addictive and dangerous. We all should have a conversation about preventing drug misuse and overdose. Be safe. Only take opiate medication as prescribed. Always store in a secure place. Dispose of unused medication properly. Understand pain. Treatments other than opiates are effective in managing pain and may have less risk of harm. Talk with your healthcare provider about an individual plan that is right for your pain. No addiction. Addiction is a chronic disease that changes the brain and alters decision making. With the right treatment and support, people do recover. There is hope. Be prepared. Many opioid overdose deaths occur at home. Having naloxone and opioid overdose reversing drug means saving a life. Know where to get it and know how to use it. Next. And the most thing, as I say, celebrate recovery. And as not Recovery Month, we celebrate recovery every day. Thank you.
All right. Reverend Casey, we thank you for that presentation, and I don't want to presume that there aren't any questions from our listening audience even now. I do have one or two that I would like to ask you, and again, I would encourage anyone that's listening, if you're having a question, feel free to ask it now. You mentioned that you were, I don't recall if you said how long you were in your addiction before you got help.
Okay.
I was wondering what motivated you to get out of that situation? And the second question is, did you experience relapse? And how often?
Okay. I was at the point of my ability to dream had died. Every day was Groundhog Day. Every day was the same day, using it, getting and using and getting more. I was in a all joints. They call them all joints, a shooting gallery, you know, where you inject drugs. And a person in there told me I needed to get some help. And so the blessing was at that point I didn't have any insurance or anything because I wasn't working, you know. The blessing was I had been in the service. So I went to this VA hospital. They say it was a 3-month program, 6 months, and I have another guy who was up there with me said I was the worst he ever seen come before or after, because I was at the point where I was weighing about 130 pounds, shaking, talking in parables, laughing, thinking you knew the rest of it, that kind of stuff. And I was up there, and as I said, when I got there, I was there I went in June 16, 1980. I got out January the 6th. No, January the 9th, 1981. And I was using before I got off the ground. See, my friends came to pick me up. Okay. And however, I didn't stay. It took me about 5 more months going back, and then I did get involved. I moved into an Oxford house. I did got in fellowships of Narcotics Anonymous, now Alcoholics Anonymous, and I had something that relapse did wonders for me, because it gave me opportunities to compare using against not using, because from my very first beginning of using, I never not used. And so that's what I did, and okay. Hope I answered.
You did. And so you say that you relapsed once or a number of times. And when that does happen, what would you say to those? Because I'm sure there are some that are listening, yeah, who might be in this situation right now and they have relapsed a couple of times, yeah, and probably feel like there's no hope in continuing. Yeah. What would you say?
You never stop trying not to use. You always, as long as you try not to use, you get some help. And don't give up on yourself. See, I didn't give up on me. I had a taste, and the thing is, the blessing about relapse, you already had a taste of recovery.
Okay. All right. Very good. I had another question for make sure we don't have one coming in. All right. For someone who may not have been with us at the very beginning of the program, you said you're celebrating 40 years, yeah, of being clean. Yeah. Now, I know who you give the credit to.
Yeah, that's right.
Jesus Christ, your Lord, yeah, and your Savior.
Yeah, yeah.
But I believe you would also say there is value in some of these treatment programs like the 12-step program. Can you address that for us?
I didn't get the opportunity to grow up in the church. Okay. You know, I got to religion through college. But however, I got through spirituality through AA and NA, working the 12 steps of recovery. It gave me opportunity to understand. See, the thing is, what I say about the spirituality part of it is that, see, anyone can come there. Everything is inclusive there. Because it's a difference. It's a difference when you come in here to look good on Sunday morning, and there's a difference when you go in those rooms to save your life. It's totally different.
Amen. So you endorse the programs.
Yeah. Yeah.
All right. All right. Very good.
I still go.
Okay. All right. Very good. Very good. Any other questions? Well, again, yes. We need to come to the mic. Or I'll repeat it for you. All right.
I just have one question. In the last workshop we had here, they gave us samples of the naloxone. Does that have an expiration date?
Yes, it does.
Okay. Okay. So what, you don't know what the expiration is?
No,
Just,
I know
it
this-
just varies.
I'll tell you, I'm gonna help you out with this. This is, October, it has,
Oh,
it's
okay.
on there.
Oh, okay, I was just wondering, because I still have mine, and I just wondered
Yeah,
if I
oh.
needed to just pitch it,
Yeah.
throw it out.
Yeah, it's an explanation there. 'Cause,
Okay.
Trustee Pam told me that.
Thank you.
Indeed, there is an expiration date, and as Reverend Casey mentioned, we're going to have a workshop on the naloxone treatment, and at that time, they will also give us some fresh kits, naloxone kits, to be on hand. All right. Well, Reverend,
Yeah.
thank you so very much
Thank you.
for that informative presentation. We really appreciate you taking the time to share with us, not only with us, but we know that you are using your experience, your 30 years of experience as a counselor and a leader in this effort, as well as the experience you had before
Yeah,
to help folk today.
yeah.
So we thank God for you and for taking the time to be with us and helping us in this workshop. Indeed, you will hear from us again in the future.
One more thing about, that helped me get into recovery.
All right.
Not only I couldn't do anything for people, but people had stopped asking me.
Okay. Okay.
And this is the turnaround. People ask me to do things now.
All right. Good stuff. Good stuff. Well, thank you, sir. And thank all of you that have taken the time to tune in to this workshop. We will have several workshops through the course of the year. And we invite you, we indeed will keep you informed of those. We will advertise them on our website and on our Facebook page. And we invite you not only for you to tune in, but get your family and your friends to come and get this information. It's information so desperately needed. Again, it's not just about illegal opioids, but also about the legal ones, the ones that are being prescribed and that are addicting us in such a marvelous way. So please stay tuned. We have another workshop coming up in March, and you'll hear more about that in the not too distant future. God bless you. Stay safe. Stay connected. And we hope that you will tune in on Sunday morning at 11 o'clock. God bless you and have a good night.